And if you take nothing else away from this topic today, I want you to take away to be thinking about stroke as a brain attack. If I would say you're having a heart attack, people automatically have been trained so well to realize that is a medical emergency. You need to seek 911, get to a hospital. But when you hear the words they're having a stroke, it often does not bring that same sense of urgency. But it really should, because the time during the stroke is brain cells. And with every minute that ticks by as they are having that ongoing stroke symptoms, there is the potential of loss of brain cells. So what I want you to take away from here is think of stroke as a brain attack, act immediately, and call 911. That's the most important thing of the whole topic today. Let's talk a little bit about some facts about stroke. There are risk factors for stroke, which does increase with age, but it can occur at any age. We have newborn babies that have strokes. We have the 100-year-old grandparent that has a stroke. Every 40 seconds, someone in the United States has a stroke, and every 3 minutes and 14 seconds, someone dies of a stroke. Stroke is a leading cause of serious long-term disability. People don't always die, but they are left with severe disability. Disability in motor function, whether they can't walk, they can't use their arm, disability in cognition and not able to think clearly. There's just so many things that lead to a disability that is irreversible at times, and they are left with that lasting disability to learn to live with. In 2014, about 38 people hospitalized for stroke were under the age of 65 or older. So let me say it again. They were under the age of 65. So I know we talk about stroke being and thought of often as an older person's disease, but 65 to me isn't all that old. This graph, what I want you to take out of it, this is a graph of the years of 2018 to 2020 and the stroke rate of death. And so in the lighter pinkish purple colors is the low rates of death, and the deeper dark purple areas are where there is higher incidence of death related to stroke. And this is for age of 35 years and older. So as you know, Kansas is kind of right square in the middle of this diagram of the United States. But nevertheless, there are deaths that occur around us. So what is a stroke? Let's talk about that. There is a hemorrhagic stroke or an ischemic stroke, or the two types of stroke. So we're going to talk a little bit about each. We're going to start with the ischemic stroke, which is a clot. It is a clot that forms in the blood vessel, and it occludes or obstructs the blood vessel of the brain, therefore blocks blood getting to your brain tissue. And that is why you have symptoms of a stroke, because that brain tissue is no longer getting a blood flow, and it is essentially dying because it's not getting the nutrients of the brain. Ischemic strokes are about 87% of all the strokes that can happen. And it is also one of the most preventable type. And we're going to talk about that when we talk about prevention and what can be done to help maintain a healthy body. Some of you may have heard the word TIA, which is transient ischemic attack, and that is a temporary blockage of blood flow. So it's that same thing that we were just talking about, but it lasts less than 5 minutes. So the person starts to believe or see that they're having an arm weakness or a facial droop or slurred speech, but less than 5 minutes and it resolves. And people don't realize that that's a warning sign of a future large stroke that is likely to occur. And so if somebody's having TIAs and it lasts for a short time, you still need to seek medical support and investigate what's causing that and what can be done to prevent it so you don't go into a full-blown major stroke. As far as a hemorrhagic stroke, that's a bleed in the brain. It weakens the blood vessels and they rupture. There's two main causes. One is aneurysmal and one is AVMs. And the diagram shows kind of a balloon-like aneurysm that is growing. It fills up with that blood. And the most common cause of that bleed is high blood pressure. And so that pressure builds and it fills that balloon and it stretches it and it explodes or bursts, much like a water balloon would. And with that, then we now have blood vessels that are not getting the blood that they need within the brain tissue, and it's causing that hemorrhage within the brain as well. Signs and symptoms of a stroke. It is a sudden change. It is like flipping a light switch. It's not something that's going to come on slowly over a week or two. It is a flip of a light switch. Someone woke up, they're just fine 1 minute, and the next minute they have a sudden change. It can be a weakness or numbness of a face, arm, or leg, and usually it's affecting only one side. So it may only be the right arm or the right leg, or it may only be half the side of the face. Confusion. It can be either confusion in speaking, they slur their speech, they speak words that are ineligible to be able to understand, or understanding speech. You're talking with them, you're giving them a simple command like squeeze my hand, and they don't understand what you're needing or wanting done. Trouble seeing in one or both eyes. So visual disturbances can present in the form of blurred vision, double vision. Sometimes people lose part of their vision field, and so they may only see like what is on their right side of their body, and they don't really see anything that's on the left side of their body. Or they may have one eye just as suddenly as blind, and they can only see out of the other eye. Trouble walking, that can be present in the form of complaints of dizziness or in loss of balance or coordination. So someone that can normally walk down a corridor without any gait disturbances, but now they can't keep their balance. Maybe they can't sit erect up in a chair, but they've always been able to sit straight up in a chair, and now they're sliding off to one side. Severe headache with no known cause. When we were talking about the hemorrhagic strokes and the bursting of a blood vessel that causes that bleed, one of the most common complaints with those type of strokes is it's the worst headache I've ever felt in my life. And they'll have that symptom right before the bleed occurs. So how do you diagnose or suspect that somebody's having a stroke? What do you do to determine that? There's an acronym called FAST. With that, it is one that we use here at the hospital. It's one that sometimes the ambulance crews may use. It's looking at the face to see if there's any, the F is for face, to see if there's any facial drooping. So ask the person to smile. Do they have an equal rise of both sides of their face with their smile? Ask them to open their eyes wide open. Do they open and are the same symmetry? Arm weakness. Are they showing weakness on one arm? Do they have a weak hand grip on one side? You can ask them to hold their arms up in the air at an equal level and have them extend out and hold them there for like 10 seconds. And people that are having some stroke difficulties, they'll have a drift where they can't maintain that arm up in the air. It'll slowly drop down toward the floor. Speech difficulty, again, that can either be in spoken words or in comprehending of speech when they are spoken to. And we talked about how important that time is, and it's a brain attack, and it's time to call 911. At LMH, we use a BFAST, which adds just a BE in front of the FAST that we just talked about. The B stands for balance. So again, if you're able to see the person try to walk, if the patient or person is sitting in a chair and they're not able to sit upright, but they do slump over to one side or the other, and that's new and unusual for them. And then we talk some about the eye visions that they can see, that double vision, the blurred vision, the visual fields that disappear. Those sudden changes can be signs of a stroke, and that could be the only thing that they have. They may have full body movement, they may be able to talk and understand, but they just have a vision difficulty. So it doesn't require you to have all of these things, but any one thing that is present and is a sudden onset is enough to be concerning and for you to seek 911. Let's talk a little bit about treatment of stroke. We'll talk about it by types. We talked about the ischemic stroke, which is that clot that forms. There is that time factor that I was talking about. In the treatment of stroke, we diagnose it as last known well. We need to know when that light switch flipped. When were they last normally functioning, and at what time did you see the first symptom of a stroke? So if you're with somebody and you think they are suddenly changing, take note of that time because that's important. We give thrombolytic IV meds, which is a blood clot buster. So if they have a clot that's formed and we're trying to break that clot up, we only have 3, maybe 4 hours from the time that the initial signs and symptoms of a stroke presented to be able to give that medicine. So upon arriving into a hospital setting, the first thing they're going to do is they're going to take a blood sugar and they're going to send you to a CT scan. The blood sugar is just to make sure that you don't have a low blood sugar, because sometimes when people's blood sugars drop low, and those people that are diabetic, you may have seen or how they can respond, but they can, mentation can be affected with that. Their speech can be affected by that. So we want to make sure that it's not a low blood sugar that is causing the symptoms that we're seeing. The CT scan is going to be a quick scan of the head to make sure that it's not a hemorrhagic bleed, because the treatment for that is totally different than what we will do for an ischemic. Again, ischemic is 87% of the time, it's going to be an ischemic type of stroke. So once we've confirmed that they have a normal blood sugar and there's not a bleed within the brain, then we'll consider whether they are within the window to receive the thrombolytic IV. And again, that's within the first 3 to 4 hours of the time of the initial symptom of a stroke presentation. We call it from the last known well, 3 to 4 hours. There are a few things that may be contraindicated that would rule you out from being able to receive that medicine. Those things might be a recent surgery. You may be predisposition to blood bleeding, be ulcers, or have a blood disorder that causes you to already have a predisposition of bleeding. So there may be some reasons that we can't give it, and we've got a checklist. We'll go down that with you and the family to make sure you're eligible for it. The consent then to receive it, we'll give it. Generally, we have pretty good response to get them patient to break up that clot and get them back to what they're considered baseline normal. But after the administration of that IV medication, if they have not returned back to baseline, then the next thing we would consider is mechanical thrombectomy. And what that is, we don't do that here at LMH. So it would send you, the patient, on to a larger facility to do that. And it is a guided wire that they will introduce in an artery at kind of your groin level. They'll thread it up that artery up into your brain to the level of the clot. And they will then be able to capture that clot and pull it back out with that guide wire. We've had a lot of success with that as well. And that's fairly new, probably in the last 7 years or so that we've been having mechanical thrombectomy and the advancements in that modality. The time frame, again, talking again about why it's so important to be time sensitive and reporting to the hospital as soon as you see the first symptom. We have a 6 to maybe a 24-hour window from the first symptom of stroke to be able to do mechanical thrombectomy. The qualifications for that, part of that will be depending on where that level of the clot is within the brain, because it can be in areas that they cannot reach with a guide wire. But if it's in a large vessel occlusion, they have had great responses and great turnaround by retrieving that clot out and reestablishing that blood flow. With those ischemic clots, they're going to try to figure out what caused it. Why did you have a stroke in the first place? So there's a couple of things. Those clots, although a lot of them are blood clots that are forming, and they can be broken up by that thrombolytic. Some of them might be also plaque induced. And so one of the common places is your carotid arteries. And so some of you may have heard that people have had surgery on their carotids, a carotid endarterectomy. That's establishing that blood flow through those veins in your neck that feed your brain and making sure that those are wide open and have good blood flow. Another common cause is atrial fibrillation, which is an irregular heartbeat within your heart. And it causes like some pooling of the blood within the heart walls. And that pooling can develop a clot. And then that clot will eventually get pushed out of the heart. And if it goes upward into the brain, it will lodge, and that will cause your stroke. Peripheral artery disease in the lower legs sometimes will create blood clots that begin down there, and they break loose and they will circulate through the body, and then they will become lodged in the brain, and that will create your stroke. So trying to identify where is the clots coming from and what's causing them will then lead to the next treatment. With any stroke, rehabilitation in either occupational physical therapy may be needed depending on what type of lasting symptoms that the patient is experiencing. On a hemorrhagic stroke, if we talk about the bleeding, as I said, one of the first things they're going to do is do a blood sugar and then take you into a CT scan to verify if there's bleeding. If there's bleeding, then initial concern is to try to identify what caused, control that bleeding, and then once that patient is stabilized, looking at what treatment might be necessary. So in what we were looking at as those aneurysms, they can coil aneurysms, meaning they will thread a little coil wire up into that ballooned aneurysm and kind of fill it in so that it can no longer accept blood. They can clip aneurysms so that blood can't get into that and it won't burst. So there's lots of surgical or radiological interventions. Radiology does the coiling typically. And then again, rehab would be another possibility. An ounce of prevention is worth a pound of cure. That was something that was coined by Benjamin Franklin, and certainly is something well said when we're thinking about stroke. So when we're looking at risk factors for stroke, there are a handful of them that are considered uncontrollable risk factors. So we all age with time, and as stated earlier, more advancing age brings on a little higher risk. Family history. If you have an immediate family member, be it a parent, a sibling, a grandparent that had a stroke in the family, then that predispositions you to a higher prevalence of having a stroke. When we talk about race, Black Americans have a higher risk to stroke. When we talk about gender, women tend to have more strokes than men. However, men happen to have them at a younger age than the women. And then if the individual has a history themselves of either having a prior stroke, having those TIAs, or having a previous heart attack, that also leads to the possibility of having a higher risk of a secondary stroke. The cardiovascular disease in itself, it includes the heart attack, it includes the diabetes, all of those type of diseases roll together, and stroke is in there with them. And so if you have any of those, it does add to that higher likelihood of presentation of a stroke. So these are things to be aware of. They're not necessarily anything that we can treat, because you can't stop your aging. You can't really change your family genetics. But just knowing that you already are at a higher predisposition means that you need to really focus really heavy on those things that we consider modifiable. So on the modifiable, we look at a goal of a blood pressure of 120/80 is typically where we're looking to have a management for blood pressure. Now, you and your primary care physician will seek a common goal, but if you are monitoring your own blood pressure and you're seeing that you're consistently above 120/80, I would encourage you to seek out your primary care physician, talk it over with them, see what they can do to help manage that blood pressure. As I stated earlier, high blood pressure is one of the most common causes of a stroke. Having a history of being a smoker will also predisposition you to a stroke. I have read some articles that say up to 50% higher if you were a heavy smoker. In that cardiovascular realm, and most of us have heard thinking about cardiac health and a healthy diet, it's the same thing for stroke. Avoid the high fats, limit your salt. The high fats increase your cholesterol, which then will increase the likelihood of having clots formations. The salt tends to cause the body to retain fluid, which then will cause your blood pressure to be higher. Physical inactivity is also something that you need to monitor. The best thing that we would encourage everyone is to do moderate physical activity 3 times a week for 30 minutes each time. And that may be simply taking a walk, get out, be physically active for 30 minutes. If you're able to, you can layer in a little bit more of a intensity in that, but just being up and moving goes a long way than being sedentary. One of the causes of the term you may have heard is deep vein thrombosis. It's the clots that form in the legs. And sometimes those can happen just for people that sit and aren't moving. For example, those people that drive the 18-wheel trucks and their life and job is sitting in behind that steering wheel of those big trucks and driving down the road, they are more likely to have those deep vein thrombosis that develop in the leg, and they can then break off and circulate through the body and end up in the brain. So those type of activities there where you are in sedentary position, get up and move around. It's very important. Obesity, that kind of ties back in with diet and weight management and doing the things with activity to help control that. Now, there's another set of modifiable risk factors that are disease management. And so if you're diabetic, making sure that you're monitoring your blood sugars, trying to keep them within a normal acceptable limits for blood sugars. If you know you have high cholesterol, seek help with your physician. We have a lot of good medications that can help try to control cholesterol levels. Diet management will also help that, reducing your fat content in your diets. Atrial fibrillation, the treatment for that. There are steps that we can try to do to revert the heart back into a normal rhythm. There's medications that we can also try to convert the heart back into a normal rhythm. Many people live with an atrial fibrillation for years. And so it's not in itself life-threatening, but if you have it, there are some precursors then you have to follow with your physician. You should be on a blood thinner so that you don't form those clots in your heart that can then circulate up to your brain. So just being aware if you have an irregular heartbeat, following with your physician. Sleep apnea. Sleep apnea, it can induce heart conditions. It also presents itself in not having good long periods of sleep, and your body needs those restful moments to really be healthy. And so and often sleep apnea is first identified by a spouse or someone that is living in the home, and someone else is seeing that person not have restful, even respirations. Sleep apnea is where you're breathing and then you have a long period where you kind of stop breathing in your sleep, and then you suddenly take a deep breath and start breathing again. Sickle cell anemia, that is an important one for children especially. There is some genetic testing that can be done, but childhood strokes have a high correlation to kids that have sickle cell anemia. Carotid artery disease, we touched on that a little bit about the circulation within the heart. And then peripheral artery disease is the legs that we talked about for blood clots developing.
Amy, can I interrupt just a second? Because there's a couple questions as long as we're talking about precautions. One of our members asked, what is your opinion of having the Watchman placed in one's heart? This person had AFib and an ablation, and it was an option he did not choose.
So it is a personal choice. There are a lot of studies that do show that there's been success with that. It allows you maybe not to have to take so many medications. Again, the theory with the Watchman is they do kind of coil a little pocket where that blood clot normally forms. They kind of close that little pocket off, and that alleviates that blood pooling in that pocket that might create the clot that could then develop and circulate out. It does come with some risk. My mother-in-law got one. She's doing great with it. So it's a personal decision, but there are a lot of good studies out there that say that it is very successful, and it is a way to, if you don't like taking medication orally, it is a way to lessen that.
Okay. And one other question that I think relates to this is, what's your advice on baby aspirin?
Mm-hmm. Yeah, baby aspirin's been around for a very long time. You definitely should be, under the guidance of your physician, but it is a treatment that many physicians will encourage a baby aspirin a day. What that does, it helps keep the blood cells, the red blood cells, kind of slick so that they don't want to clump as easy and maybe reduce the formation of clots. It isn't 100% foolproof, but it will help support that through that, providing that antiplatelet type theory.
Relative to that, I was actually taken off of that baby aspirin under the advice that if you have no history, and if you're over the age, I think, of 75, which I am, that there are some negatives there that might outweigh the positives. So I don't want everybody leaving this program to start taking baby aspirin.
Yes.
That's why I brought it up.
Perfect. And as I said, you need to do that under the advice of your physician.
Right.
But there are many people that do get prescribed that. But it has risk of stomach ulcers and other type of complications. So it isn't for everyone. And that's why if you have any of these precursor signs, make that appointment, sit down and talk with your primary care physicians about what you're concerned about, what you have as precursors, and formulate a plan with that physician because they can do close monitoring and adjustments over a period of time.
Okay. That's all the questions there are so far. I didn't mean to interrupt you, but I thought they were pertinent to the timing.
Yeah, and really I was done. I put up here some resources that if you are out on the internet, you can find a lot of great resources from American Heart Association. There's also an American Stroke Association. There's information out on the cdc.gov website. And then we do have on our LMH, we have a little section on kind of strokes as well. So encourage you to, research more into those areas. Those all three of those, the American Heart and American Stroke Association, are very sound programs and have a lot of good information out there.
Okay, we have a few more questions coming in. One of them is, does LMH have a neurologist or brain surgeon that can perform tests or removal of clots?
Yeah, so there are terminology here. We have neurologists, but we do not have neurosurgeons. So in what we can do here at LMH is we can do the testing of a CT scan. We can verify whether there's a hemorrhagic bleed versus a clot. We have the guidance of our neurologist that are highly trained physicians, and they can help us determine the IV thrombolytic if it's recommended for the presentation of that individual. But if there is need for removal of a clot, if there is a hemorrhagic stroke, that generally we will also transfer those patients out because they typically are going to need neurosurgery or a type of radiology intervention that we do not provide here.
Okay.
So we have neurologists, we do not have neurosurgeons, and we do not have radiology neurology specialist.
Another question, and I agree with this person because I've listened to the PSAs on TV. I've heard that an aspirin should be given to someone who may be having a stroke while waiting for an ambulance. Is that good advice?
As long as they don't have any known complication, they're not allergic to it, it's not going to hurt anything.
Right. Okay. All right. Anyone else with any more questions? I have one, and I have a wonderful family history of repetitive strokes on my father's side. My grandmother had 7 before she passed, and my father 4. Is that typical? Is that starting to go away as treatment is improved, or is that just, if you have a stroke, you're probably going to have a bunch of strokes?
Treatment has improved a lot, even in the last 10 years, maybe 15 years. The mechanical thrombectomy that I just spoke about, that is relatively in the last 7 years or so. We do have better medications now. I'm not off the top of my head, I don't know exactly when we started the IV thrombolytics, but that has been in my lifetime. And so, you're talking about people that had strokes 50 years ago. We didn't have all the treatment modalities that we do now. And so, yes, it is a little bit of historical past that you saw people continuing to have strokes because we didn't understand and we didn't have the care and treatment knowledge that we do today. However, we still have patients that once you've had that stroke, once you've seen that you're having a TIA, you are at a higher risk of having a repeated event. And so it's not uncommon to see someone come back for a second or third stroke.
One of the other statements, and it makes a lot of sense, if you're having a bleeding stroke, then taking a baby aspirin would not be wise. Is that so there is a risk, obviously, in giving somebody an aspirin before they get into an ambulance. That
is a true. The baby aspirins are not they're not like a high powered thrombolytic, but to shade to what they're saying. But I also want to emphasize that 87% of the strokes are thrombolytic, and treatment of that would be trying to break up a clot. So percent wise, you're more likely to be dealing with a thrombolytic. If the person was presenting with that, I've had the worst headache that I've ever had in my life, I might not give the aspirin, but
Okay. Further comments or questions, anyone? We have time. I don't want to rush anybody, and I know sometimes typing is an issue, so I'm going to give it a few minutes here. Okay, well, doesn't appear that we have any more questions, but I'll talk slowly because sometimes something comes up, and this is a pretty important subject, I think. I will say I know because of my wife's experience that ablations, which isn't the same as treating a stroke, they do have consulting doctors who do come to LMH and do that, because that's what happened with my wife. So
ablations of the heart.
yes.
Yes.
Yeah. So any rate, okay, well, not seeing any more questions. We'll go ahead and thank Amy for participation and Allison for putting this up together. And we'll look forward to starting back up in September. And once again, thank you all for joining us this evening. And as I said, thank you, Amy, for everything. And we appreciate it. What we're getting now is thank yous, Amy. So they're not putting up questions, they're putting up thank yous. So
you.
I appreciate everybody's participation, and we'll see you at whatever the next retroactive event is. You all will be getting a link to this on our YouTube channel, and please feel free to pass it on to other people who couldn't be here or to friends. And once again, as I said, thank you very much. Have a good evening, everyone, and we'll see you later.